Hello guys, so this is Dr. Krishna. So from today on, we shall be starting microbiology series. In this microbiology series, we shall be first focusing on the bacteriology part, right? So in the bacteriology part, from today on, we shall be discussing staphylococcal infections. So you very well know that there are wide variety of staphylococcal infections, right? So, but today we shall be discussing on one of the most important staphylococcal infection. So here we go. A case that a 56-year-old man comes to the clinic, right, with the complaints of severe headache, dizziness and blurred vision. He can't even see properly. His son complains that his father is having some cognitive disturbances. Now, what do you mean by cognitive disturbances? It means his father is lacking cognitive skills. What are cognitive skills? He is having dementia. He can't remember properly. He can't talk properly. He can't think analytically, right? So there is a problem in thinking. There is a problem in remembering the things. There is a problem in learning as well. There is a problem in speaking as well. So his cognitive things, his cognitive skills are disturbed. Now, what doctor did is that doctor have performed a CT scan. Now, in the CT scan, doctor was shocked to see that his ventricles of the brain are enlarged. There is ventriculomegaly. You very well know that within the ventricles, what do we have? We have got CSF, cerebrospinal fluid, right? So if there is more cerebrospinal fluid in the ventricles, obviously the ventricles will stretch out. Now the doctor decided to perform a surgery. So in this surgery, what you do is you put a shunt in the ventricles and you drain that all along into the peritoneum. This is called as ventriculoperitoneum shunt. Now what is the use is, if excess amount of fluid is there in the ventricles, that will be automatically drained into the peritoneum and peritoneum will absorb it. Okay. The operation was successful and the patient was shifted to ICU. Next day, the patient got severe fever, severe intoxication. He was having high fever, high rate of intoxication, and patient was complaining that he was having severe neck pain, neck stiffness. Now what doctor does is that he have taken little amount of CSF fluid by doing lumbar puncture, right? And have sent it to the lab. Now in the lab, they confirm that there is severe amount of leukocytosis, especially neutrophils. So we confirm that patient is having excess amount of bacteria in his body, and that is the reason why there is excess amount of neutrophils, that is neutrophilia. So patient is having neutrophilia, right? Now, not only that patient who is in the ICU, but the remaining patients who are on IV cannula with the fluids running into them, all of them were having the same infection. All of them were having fever. All of them were having neutrophilia. All of them were having leukocytosis. Now, upon further investigation, they came to know that there is some bacteria which is like a grape shape, cluster shape, and that is present in every one of their body. Now, they started to investigate it. And finally, the doctors themselves found that bacteria on their skin. And the doctors even examined the people outside the hospital and even they found the same bacteria on their skin as well. Then they came to a conclusion that this is a bacteria which commonly lives on everyone. It commonly lives on the skin of everyone. But if you're not sanitizing it properly, if you're not sterilizing the area properly, and if you're trying to inject something inside, with the help of the device, the bacteria also enters into your body. So as this bacteria is a normal inhabitant of the normal skin flora, so you call this bacteria as epidermidis. As we are discussing Staphylococcus, so the bacteria was given the name as Staphylococcus epidermidis. So here comes the title, Staphylococcus epidermidis. Now, one thing you are very sure that from the given explanation that Staphylococcus epidermidis is a normal inhabitant of skin. Point number 2 from the story which you learned is that Staphylococcus epidermidis mainly spreads through the devices, the hospital use devices. Okay, we shall be discussing that in detail, but this is just an introductory part. Okay, I'm just clubbing up all the things. So this staph epidermidis is not only the common inhabitant of skin flora. Staph epidermidis is also present on the scalp. It is present on the face. It is present in the groin region. It is even present on the legs and even in the armpit. What is the pathogenicity? Is that really pathogenic? No. Most of the staph epidermidis, mostly it is non-pathogenic. For example, I have the same bacteria on my body as well. If my immune system is low, if my immune system is compromised, then there are high chances that this bacteria can affect me and can be pathogenic to me. So mostly this bacteria affects which group of people? those group of people which are admitted in the hospital, because hospital acquired people, they have low immunity. So this bacteria has got a high chance, very good chance to enter into them and cause the pathogenic infections, right? Point number 3, for example, if you take centimeter square of your skin, in that centimeter square, there are around 10,000 Staphylococcus epidermidis bacteria. Okay. And as this bacteria are located on the skin, they are even responsible for the order of your body. Okay. This is something, the basic introduction which I wanted to give, right? So apart from this, another very, very important thing which you need to know is that what kind of bacteria, what are the other different types of bacteria which are normally present on the skin? I told you staph epidermidis is a normal inhabitant of your skin. Along with this, Propionibacterium acne is also a common inhabitant of your normal skin. Okay. Let us discuss in detail about the properties of this bacteria. Right. What are the properties of this bacteria? Now, regarding the properties, one very important thing which you need to know is property number 1. As you can see, this is the bacteria over here. Now, this bacteria is releasing some enzyme, whatever it might be, we don't know. Now, what this enzyme is doing is that, on the other hand, there you can see H2O2, right? This H2O2 is converted into foam. You can see the picture of foam here. What is foam? Foam is nothing but water plus oxygen. Exactly meaning H2O2 is converted into water plus half mole of oxygen. And that what forms the foam. When you have open cut surface of the wound, when you put H2O2, obviously you see foam out of there, right? So this bacteria is releasing something and that is causing this reaction. So the enzyme which we basically need here is catalase. And this bacteria is releasing catalase. So can I tell this bacteria is catalase positive? Yes. Point number 2. Point number 2 is the basic thing which I have to tell it in the starting, that this bacteria is gram positive. You know it very well. Point number 3. Point number 1 was catalase positive. Point number 2 was gram positive. Now point number 3 is that in your blood you have got something called fibrinogen, right? Which is responsible for the clotting of your blood. So as you can see, fibrinogen there. Now this fibrinogen is basically converted into fibrin. Okay. And what is this fibrin? Fibrin is nothing but the fibrin fibers. These fibrin fibers go everywhere in your body and plug that area. In this way, the fibrin fibers are like this. They just go, they completely cross-link like this and they plug that area so that there is no bleeding out of that. Now, who is doing this reaction? This reaction is mediated by coagulase. Okay. But unfortunately, this bacteria doesn't have a capacity to release coagulase enzyme. So if it doesn't have that capacity to release coagulase enzyme, will it convert fibrinogen to fibrin? No. So when it doesn't convert fibrinogen to fibrin, can I tell it is coagulase negative bacteria? Point number 3, it is coagulase negative bacteria. Yes. Point number 4. Point number 4 is that you have got urea in your body, right? You have got urea in your body. Now, if I convert urea into ammonia and carbon dioxide, right? You are converting urea into ammonia and carbon dioxide. So what is this enzyme? The enzyme is urease. And surprisingly, this bacteria releases this enzyme urease. So can I tell it is urease positive? Yes. So overall, I wanted to tell you that this bacteria has got many characteristics. One is it is urease positive, it is catalase positive, it is gram positive, but it is coagulase negative. Now, I'm pretty sure that you might be confused. What is this catalase? What is this urease? And what is this, coagulase and all? Let me classify it and make these things clear in you. Let us take, there is some bacteria in my hand here, right? This is called as a free living bacteria. Now, if I wanted to divide this bacteria based upon catalase enzyme, then some bacteria will release catalase, so I will call it as catalase positive. Some bacteria will not release catalase, so I will call it as catalase negative. As you can see there are two types. One is catalase positive, another one is catalase negative. So the bacteria which is catalase positive are Staphylococci. Bacteria which are catalase negative are Streptococci. So can I tell all Staphylococci are catalase positive? Yes, I can tell that all Staphylococci bacteria are catalase positive. So from tomorrow onwards, I'm going to tell you that Staphylococci, let us say Staphylococcus aureus is catalase positive, Staphylococcus saprophyticus is catalase positive. I'll be directly writing it down because you know that all Staphylococci bacteria are catalase positive. Right, let us continue now. We have divided catalase positive, catalase negative. One was what? It was staphylococci there, and here it was streptococci. Now we take the positive ones. That staphylococci, we take that group of staphylococci bacteria and we will see whether they are releasing coagulase or not. But you know what? Some of the bacteria again they release coagulase there, and some of the bacteria they don't release coagulase. So bacteria which releases coagulase is Staphylococcus aureus, and bacteria which doesn't release coagulase is leaving Staphylococcus aureus, remaining all bacteria releases coagulase enzyme. So what will happen when coagulase enzyme is released? You know very well, right? Now we take into consideration about the bacteria which does not release coagulase. It means there are coagulase negative organisms. Now in these coagulase negative organisms, again there are two types. What are they? There are novobiosine positive, novobiosine negative. Now what is this novobiosine? What is, I'll clear that concept in a minute, but before that just trust me that there are two groups of bacteria. One is called novobiosine positive, novobiosine negative. Novobiosine positive are, you can see here, epidermidis, staph epidermidis, staph hemolyticus and staph hominis. Whereas novobiosine negative are staph xylosus and staph saprophyticus. Right? Now, what is this novobiosine? Novobiosine is an antibiotic. Okay, then why are you discussing that? The reason is, what did I tell you? I told you that staph epidermidis, saprophyticus, both of them, as you can see from the slide back, staph epidermidis and saprophyticus, both of them are coagulase negative. Fine. How to differentiate them? You put two bacteria in front of me and tell me both are coagulase negative. Then how will I differentiate? How will I differentiate that this is epidermidis and this is saprophyticus? How will I differentiate? I will differentiate based upon the novobiosine test. That is also called as novobiosine susceptibility test. So what is this novobiosine susceptibility test? Novobiosine susceptibility test is that, for example, I take a plate, right? In this plate, what I do is I divide the plate into two halves. As you can see there, I can divide the plate into two halves. After dividing, on the right hand side, I put a bacteria by name Staphylococcus epidermidis. On the left hand side, I put another bacteria by name Staphylococcus saprophyticus. Both of them are coagulase negative. Right now I am differentiating how they are coagulase negative. How it is staph epidermidis, how it is staph saprophyticus. Okay. So on the right side it is staph epidermidis. On the left side it is staph saprophyticus. What I'll do is, I will take novobiosine antibiotic. As you can see there, I'm adding this novobiosine, I'm adding few drops of novobiosine antibiotic on the right side where epidermidis was present, on the left side where saprophyticus is present. For example, what is the use of antibiotic? Antibiotic is useful to kill the bacteria, right? So on the right side I have bacteria, on the left side I have bacteria, on the right side I have added an antibiotic. So that antibiotic should kill down that bacteria, should kill down that staph epidermidis. And yes, as you can see there, after adding few drops, right? So on the right hand side, the staph epidermidis growth has been inhibited. So you can see growth inhibition on the right side. But on the left side also you have added, right? But on the left side there is no growth inhibition. Why? Because Staphylococcus saprophyticus is novobiosine susceptible, right? It is not sensitive to novobiosine. Okay, so epidermidis is sensitive to novobiosine, and that is why there is zone of growth inhibition. But whereas on the left hand side where Staphylococcus saprophyticus was present, it is not sensitive to novobiosine, and that is the reason why there was no growth inhibition. There is no zone of growth inhibition. Okay, so I hope you understood very clearly. Right, let us move on. We have discussed what is staph epidermidis. We have discussed the story of staph epidermidis. By now, I think you might know what causes staph epidermidis, right? What causes staph epidermidis? I know you are clear with that. Because of mainly through the devices, infected devices. Now, let us discuss. For example, right now I am in the hospital. Now, an untrained nurse is putting a cannula into my vein, right? Now, how does staph epidermidis enters into my body? You very well know that this is my skin And on the skin, you very well know that per centimeter square, there are 10,000 staph epidermidis bacteria. Now there are bacteria on my skin. So that is the skin there and the bacteria is giggling on the skin. Right? Now, the untrained nurse, the untrained medical practitioner, they haven't sterilized this area. They haven't sterilized this area because they knew that they don't know it. So what they have done is they are taking a cannula now, as you can see there. Now they are inserting that cannula slowly inside. But in the meanwhile, let me tell you one thing, that there is bacteria on the skin, right? So if I zoom in into the bacteria, this bacteria has got a layer, and that layer is called as exopolysaccharide layer. This exopolysaccharide layer, it synthesizes a sticky gel-like matrix that is called as slime or glycocalyx. So you can see a jelly-shaped bacteria over there that is called as slime or glycocalyx. So when there are 10,000 bacteria over there, don't you think there will be 10,000 slimes or glycocalyx? Obviously. Now look here, this is my skin. The needle is slowly getting inserted into my skin. Now when the needle is slowly getting inserted into my skin, the bacteria there with the slime layer or glycocalyx around it, it will very fastly stick to the needle. With the help of slime or with the help of glycocalyx, as you can see there, the bacteria very fastly jumps onto the needle, it sticks with the needle. Now what happens? Now what happens is that, as you can see there, the bacteria starts dividing. The bacteria is dividing now. The bacteria divides and completely covers that needle. And right now, the bacteria releases the same exopolysaccharide layer. It releases or it synthesizes a special layer called as biofilm. And look there how exopolysaccharide is synthesizing biofilm, and now you can see there that biofilm is slowly wrapping the bacteria. Why should biofilm wrap the bacteria? Because if I put an antibiotic like clindamycin, if I put an antibiotic like tetracycline, if I put an antibiotic like gentamicin, so these antibiotics should not kill that bacteria, right? And that is the reason why they are completely putting a tent around them, building up a house like a biofilm around them, right? Which is also called as a biofilm, and then they are protecting the inner bacteria inside. You might ask, why biofilm is so strong like a wall? What is it consisting of? Biofilm mainly consists of proteins, it is consisting of DNA, and it is also consisting of a polysaccharide called as alginate. Okay, it is also consisting of a polysaccharide called as alginate. How did the bacteria enter into my body? You very well knew it now, right? How did the bacteria divide? How did the bacteria synthesize biofilm? And what is the use of biofilm? You very well know. So let us talk about the etiology. One thing you are very sure, ventriculoperitoneal shunt is one of the most important etiology. Second, how can it spread? One is ventriculoperitoneal shunt. Second is IV catheter. As I discussed, as I have given you an example. Third is vascular grafts. Whenever you are doing any grafting procedure, grafting operation, so that graft might contain that bacteria. And third thing is when you are replacing the joint, like artificial joints, knee replacement, hip replacement surgeries. So there are high chance that the bacteria can jump up onto the device. The device might be soft, looking soft and smooth, but bacteria is having a slime layer which very hardly sticks with that. And fourth and very common and the most important thing is Foley's catheter. Always and always never give Foley's to the ward boys, to the sisters to put it, because they don't know. Most of the untrained ward boys, most of the untrained sisters, untrained medical practitioners, they don't take proper measurements. You need to completely sterilize that area and then put the Foley's inside. Okay? Because Foley's is you're directly putting the infection into the person. Fine. So overall, you have seen the pictures, right, so far. Now overall, IV catheters, vascular grafts, artificial joints, and Foley's catheter. So these are the things through which the infection spreads. Okay, fine. I'm in the hospital. An untrained medical practitioner came to me. So he inserted a needle and the bacteria entered inside. Okay, what? So what? What will happen? What will happen is that I'll have some symptoms. What are those symptoms? I'll have rising temperature, fever. The place where the device was inserted, I'll have severe pain there. And third important thing is I will have local signs of infection. Okay, local signs of infection. Fine. The complaints which you told me were so simple. Are these the only complaints? There are no complications for staph epidermidis? There are very severe complications. So now let us discuss the complications of staph epidermidis. Complication number 1. We shall club all of them later on, but let me give an explanation for each one of them. Complication number 1. You can see this picture here. Now what I am doing is, I haven't sterilized the patient's hand and I am simply injecting or simply inserting a cannula into the patient's vein. Now what is happening? You can see the bacteria in the vein there, right? Now this bacteria, as you can see, slowly it is going up. It is going up, it is entering into the right heart. From the right heart, the bacteria enters into the lungs along with the circulation. From the lungs, the bacteria enters into the left heart. And from the left heart, the bacteria enters into the aorta, and now the bacteria is in the systemic circulation. So systemic circulation supplies blood everywhere in your body, right? So in the same way, the aorta, within the aorta, there is a lot of bacteria now. Can I call this condition as bacteremia? Yeah, obviously. This discussion which I have given, this explanation which I have given, now in this explanation, I have repeated right heart, left heart and all. So this, don't you think this bacteria is roaming within the heart for a long time? Yeah. First the bacteria has to come, then it has to go to the lungs, again it has to come, again it has to go to the systemic circulation. So this bacteria was roaming in the heart for a long time. So don't you think this bacteria will damage some structures in the heart? As you can, if I zoom in, as you can see the valves there, mitral and tricuspid, don't you think this bacteria will sit on that valve and damage the valve? Can I call it as endocarditis, valvular endocarditis? So complication number 1 is valvular endocarditis. Complication number 2, the same picture, you see the bacteria now slowly ascending into the carotids. Now it will enter into the carotids, and above what is there? You have got your brain and meninges covering out of that. So this bacteria is entering into the meninges and damaging the meninges, and that is the reason why meningitis. So signs of meningitis are neck stiffness, right? And that is the reason why when I was discussing the case in the beginning, I told you patient was having severe headache and neck stiffness. You remember? So this is the reason of that. Point number 4. For example, a new patient came into the hospital. Now what we need to do is we need to replace one valve. A new valve, a new mitral valve has to be replaced in that. So I'm putting a prosthetic valve inside. If I don't take proper measurements, if I don't follow proper hygienic environment, if I don't sterilize the area properly, don't you think through this prosthetic valve, the bacteria can easily enter into the heart and can cause direct valvular endocarditis? Yes, you can see there that this is a prosthetic valve causing, and this is the picture of the prosthetic valve, and this is a picture of prosthetic valve endocarditis. Okay. The last point is sepsis. Obviously, as I told you in the picture there, in the mechanism there, that when the bacteria enters into the systemic circulation, obviously it will spread everywhere and cause sepsis. Point number 1, which you can see there, point number 1, valvular endocarditis. Point number 2, sepsis. Point number 3, meningitis. Point number 4, prosthetic valvular endocarditis. Okay, so you understood what are the most important complications which are happening with the help of this bacteria. When I was discussing the classification, look at the classification here. When I was discussing the classification, I told you that some bacteria are coagulase positive, some bacteria are coagulase negative, right? Okay, fine. Then what is the use? Why, if it is coagulase positive, if it is coagulase negative, why should I be bothered about? The reason is organisms which are coagulase positive are more virulent. Organisms which are coagulase negative are less virulent. That is the reason why Staphylococcus epidermidis comparatively to the remaining staph epidermidis is less virulent. How? Can you prove me? Yes, when you watch my next lecture on staph saprophyticus and staph aureus, then you will get to know that how dangerous those are and how less virulent and less dangerous staph epidermidis is. So, coagulase positive organisms are more virulent, coagulase negative organisms are less virulent. Okay, how do I find it? Coagulase positive organisms, when you culture them, they appear as golden yellow colonies. But here they appear as white colonies. So obviously when they are more virulent, they will be more pathogenic when compared to them. So they are coagulase negative are less virulent, so they are non-pathogenic. Fine. We have discussed everything regarding the staph epidermidis. The last point I want to tell you is the treatment which you give for staph epidermidis is an antibiotic by name vancomycin. Okay, fine. So this completes our discussion of staph epidermidis. In the next video, we shall be discussing the remaining parts of Staphylococcus. Thank you so much.